All right, so it is exactly 2:30. So we're gonna kind of get things kicked off and start rolling here. So the one thing I did do last time is I actually failed to do on our meeting yesterday is I didn't actually do introductions. So first of all, for anybody that does not know me, there's probably quite a few of you on here that haven't actually met me. You may have seen my name in passing, but my name is Tom Zucker. I'm the Director of Health Information Technology for Fort Drum Regional Health Planning Organization, and we are one of the entities that participates in the telehealth partnership. And I have a great pleasure working with another awesome organization, Adirondack Health Institution, and I will let Katie introduce herself and her organization.
Yes, hi everyone. This is Katie Cook from AHI. The North Country Telehealth Partnership, which a lot of you have probably heard me speak about. We've been around since late 2014, right, Tom?
Yeah, you guys were formed right about the same time we were when District took off.
Right. So we're not a new organization by any means. And, and for anybody who, just a quick housekeeping, you don't need your camera on. So you can turn that off, as well as make sure your line is muted. So yesterday's session went really well. I do see a few names that were on yesterday as well. So I'm assuming you're in a setting where you're providing both mental health and primary care services. So thank you for taking the time to join us twice. Today's focus is going to be around the OMH and OASAS side of things, specifically, obviously, behavioral health and substance and opioid use treatment. If you guys have questions, start firing them off in the chat box. I thought what Tom and I did yesterday, we did a quick update on things. So Tom, I'm just going to provide a few brief updates, overview on OMH and OASAS and kind of their position on telemental health and telepractice throughout this pandemic. So with OMH, they actually came out with a very comprehensive and consolidated telemental health guidance document on March 30th. And OMH has really followed along with DOH in allowing telephonic visits, as well as telemental health, as they call it, in light of the pandemic. So you can provide OMH services if you're in a licensed facility or if you're an OMH designated service using telemedicine or telephone. So those are some updates. And then OASAS, same deal. Telepractice, as they call it, can now be done telephonically. OASAS has also expanded the eligible practitioner types. They're now including certified recovery peer advocates, CASAC-Ts, and provisional QHPs, in addition to the already allowed practitioners. So during the duration of the declared disaster emergency, telephonic delivery is an acceptable means, and OASAS has expanded their list of eligible providers, and those are all reimbursable services too. During the emergency, peers can deliver services that are authorized and reimbursable via telepractice or telephone, and these services shall be reimbursable by Medicaid and commercial payers. OASAS is also saying, as is OMH, that a provider or staff member's home is an approved distance site for reimbursement. So those agencies have really expanded upon their regulations to allow for you to reach your clients in your home. And I know now more than ever how important mental health care is, and really being able to access those individuals.
Excellent. Yeah, and so these updates are being kind of fired out from all sorts of different organizations, and we kind of gave this caveat kind of later in the presentation, but these are the interpretations on which we're reading these regulation changes and these waivers for this specific emergency. And we're doing our best specifically to ensure that we're interpreting them correctly. However, we are certainly not perfect, and so these are strictly our interpretations. These are not these have not been 100% vetted, but there are the best of our knowledge. And if you've run across something different, please chime in the chat section. Let us know if you have information that's either different, or maybe there's an update that we didn't quite see yet. This is really a group participation. We're trying to interpret all this stuff and make sure we stay on top of everything as much as we can. But like I said in the beginning, it's being fired off so fast to us. We're not always perfect, but we try to be as current as we can. So once again, there is no specific format for this presentation. I appreciate Katie agreeing to do this with us, because these types of formats are very difficult, because we don't really have a specific guidance to go by. It is basically relying on interaction from the participants. So if you have a question, or if you have something to participate, please enter in the chat box. We can also unmute your line if it's a more detailed question and we need to interact with you a little bit. But to make this session the most, we need participation from you guys. So we did get a question from Tammy, and can you clarify what services are the peers able to do?
Yeah, so I haven't seen anything from OASAS on exact services. What OASAS has put in their telepractice waiver update, the second iteration, as well as their FAQ document, both of which are on the FDR HPO telehealth site and the AHI telehealth site. So please refer to those websites to find these documents. They've said peer services delivered by SERPAs are allowable services and may be delivered by providers who have submitted a telepractice attestation or who have previously been approved to deliver telepractice services. During the declared emergency, peers can deliver any services otherwise authorized and reimbursable via telepractice or telephonic means, and that these services shall be reimbursable by Medicaid and commercial payers. As far as I understand it from like a general understanding, and I'm trying to pull up this document really quick because OASAS did give a few examples of services that would be allowable during this time, but it wasn't specific to peers. And just give me 1 second. I'm waiting for my PowerPoint to open.
Yeah, and actually, while you do that, I'll just give a quick update. So everybody does know we are recording this session, and we're going to try to take the questions and the applicable answers to those questions and make them available after this presentation in a question and answer kind of a summary for everybody, as well as the video is going to be available afterwards as well. So. So you don't have to write stuff down. We'll provide this to you afterwards.
Thank you, Tom, for clarifying that. So Tammy's question around services that peers can do, while they have not stated exact services, the general OASAS telepractice guidance says services to be delivered are those allowable under current program regulations or state-issued guidance as clinically appropriate, and include assessments, individual and group counseling, medication management, and collateral services. They also have a bullet in there that assessment, counseling, and other non-medical services may be provided using telepractice by CASAC-Ts, unlicensed staff, peers, and individuals who possess a limited permit. So hopefully that answers your question.
Yeah, that's kind of a tough one without any specific guidance, but that's, we're referencing it directly, from the information that's been provided to us. So, so if that didn't, Tammy, you can, please, oh, she says yes. Okay, excellent. So next up, we have a question. What is your understanding for the modifiers used for APG coded claims, meaning the services, is a 90832 with a 95 modifier, but what are we billing the G code, specifically the G0396 code?
My first thought is, Millie, you need to direct that question to the general DOH Medicaid guidance, because both OMH and OASAS in terms of billing are continuously referring back to the DOH Medicaid billing guidance. So I would refer back to that in terms of APG coded claims. I'm like toggling between 6 different documents right now. So I may need to follow back up with you on that. But I would refer to the DOH guidance on how to bill if you're using or not using APG coded claims.
Excellent. So this is an interesting chat. I'm sure everybody's seeing it in their chat. So the chat was originally posted from Tracy, but Tracy's saying it wasn't from her. But they, so you have a twin out there, Tracy. So the original posted question was, as of right now, when will telephonic services be ended? So and this is kind of applicable to all the waivers that are out there. These are all in place until the emergency has ended. So if there's specifically New York State waiver, it's going to be when New York State ends. If it's a federal waiver, it's going to be when the federal declaration ends, or you hear something otherwise from the appropriate authorities. So that is our understanding. You need, is that your correct understanding as well, Katie?
Yeah, I mean, if I had a crystal ball, that would be great. But it's really going to depend when all of this dies down, and we have no idea when that will be. But this lends itself into a point that Tom and I both made yesterday, which is really important to make, that if you are an agency that prior to this pandemic had never done any sort of telehealth, whether it be telemental health or telepractice, and you're now, doing the telephone visits, or you're using a platform that you kind of just picked up really quickly, start, I know this is a crazy ask right now, but start thinking about the post-pandemic situation when these regulations kind of go back to the way they were before. And we can't predict that, OMH and OASAS may leave some things in effect. I mean, that would be a perfect world. Maybe they'll say telephone visits are going to continue to be allowed because we saw such success from it through the pandemic. We don't know. But plan for things going back to normal. Plan for the fact that you may not be able to provide telephone visits beyond the pandemic, and make sure you're setting up a program that, that your patients will still be able to use with you when this is all over.
Excellent. Yeah. And that's a really good point. And we got this on the webinar that we did yesterday. The fact that patients are really enjoying, they find it very convenient to interact with care providers with whatever discipline, via the comfort of their own home with a cell phone or from their computer. So patients are really, really liking this. We're hoping that this is really going to demonstrate, that this is actually going to help how patients stay more compliant as well. So hopefully this is the positive that does come out of this scenario, is that this shows that this is an effective means of treating and interacting with patients. So so make sure that if you are implementing, these services, like Katie was saying, that you're not necessarily investing a ton of money, because you may not be able to continue using that after this whole thing is done. So be mindful, if you're expending capital to meet the needs today, that it's not, that you're actually going to be able to use that capital investment later. So. Let's see here. So we have a question from Aileen. So the attestation changed from last week to this week. It looks like they're tightened up the security piece. Is that your interpretation as well? Yeah, so I was kind of reading that myself, and it does appear to be. Was that kind of the same feeling that you got, Katie, or?
Yeah, OMH at least, and I'm looking into OASAS right now, OMH updated their self-attestation of compliance for telemental health as of Monday. And number 3 on the certification says that confidentiality will be maintained as required by New York State mental hygiene law and HIPAA privacy rules. They do have a note in there that HIPAA confidentiality requirements have been relaxed to permit service delivery via telehealth. But it says New York State confidentiality requirements found in mental hygiene law section 33.13 remain in effect and apply to all programs and services regulated by OMH, but do not prohibit service delivery. So I'm looking at that and thinking they still want you using HIPAA compliant and even 42 CFR Part 2 compliant if you can find it technology. And that would exclude some of the platforms that HHS has stated would be acceptable right now, such as FaceTime, consumer-facing Skype, I think Google Hangouts, and Facebook Messenger.
And that and that's a couple of the questions that I got. They're saying, well, hey, we're hearing that HIPAA was relaxed and all this stuff, and yes, it has, but as everybody that works in the behavioral health and substance abuse understands that you get that specific area of practice has a whole nother separate section of regulation. So somebody said, well, they're referencing New York State. Well, New York State has suspended and has relaxed a lot of that stuff, but that was not my interpretation. They're saying, despite being relaxed, they're saying, our interpretation is that you still need to meet those requirements for both New York State mental health laws and 42 CFR Part 2 stuff, if that's applicable to your organization. So that's a great point, Aileen. I really appreciate you bringing that up. We did have a question from somebody that actually emailed in, and I said we were going to try to get to this in the beginning because she may have to jump off early because as everybody's getting overwhelmed with webinars and information stuff like that, so she had a conflicting meeting. So this is from Colleen O'Neill from Samaritan, and her specific question was, I was wondering if there was any guidance about 15-minute phone calls and billing in CPT codes. I know previously it had to be a crisis, but we're doing a lot of check-ins with people a few times a week, but not necessarily a full session. Someone had said they said they saw something had come across from Blue Cross Blue Shield, but I haven't been able to put my hands on it. I can only be on the call briefly today, and that's basically her ending of the statement. So this is something we saw. And Katie, were you able to look into that, or you have any comments regarding that?
So I did reply to her with links to the thing is she was in a hospital setting, so I wasn't sure if the question was geared towards an Article 28 or Article 31 setting. So I sent her both the OMH guidance as well as their FAQ document and their telehealth modifier spreadsheet and the DOH FAQ document. And she did actually just get back to me a few minutes ago that those resources were really helpful, but it still didn't answer her question. So I'm not entirely sure how to answer her question because I haven't seen anything in the OMH FAQ document or even the DOH one outlining anything about a 15-minute like kind of crisis related phone call. I have the OMH FAQ document open right now, and they have like 70 plus questions on this, but I'm short of, all the questions that are in there. I don't know, exactly what she's looking for. So if anybody has information on the line about 15-minute check-in phone calls in the OMH space, please let us know. I don't have much more information than what I sent her, which I thought would cover it.
Yeah, and I looks like Tina just jumped on with us, if I'm not mistaken. Tina, I don't know whether you have microphone capabilities, but if you wanna, I can unmute you if you do, and if you have anything to add or if you want to clarify that question, I can unmute your line here. So you are unmuted, Tina. Do you have any clarification to what what we were looking for, or I'm not sure if she's able to.
Oh, she lost connection when she started talking.
Okay. All right.
Well, you can type it in the chat box too.
Yep.
But we were just discussing, Tina, trying to answer your question, but we're not entirely sure under what situations you were asking about it. And if it's not addressed in the guidance documents that are out, it's tough for us to really say, because I do really want to applaud the state agencies and our federal payers in these very comprehensive documents that they've put out that address a number of situations. You know, if we can't find the answer in there, it may warrant further questioning from OMH. And she's saying she's asking from the Article 31 setting. I mean, between the telehealth modifier CPT code spreadsheet I sent and the OMH FAQ document and the DOH FAQ document, I would hope that the answer to that would be somewhere in there.
Excellent. Yeah, and you know, like we were kind of saying earlier, you know, we're doing our best to try to answer all these. You know, we may not be able to answer everything, but you know, we'll at least try to direct you, you know, to a location where you can get further, you know, further clarification if needed as well. If there's any questions, please make sure that you guys submit them in the chat box. Once again, you know, this is kind of driven by you guys as the participants. So, you know, we don't have anything specific that we're presenting to you guys. So the more you guys get to interact with us and each other, it's going to be probably the most meaningful meeting that we can have. So just keep that in mind. If you have something relevant to add, you know, raise your hand. We can unmute your line. You know, there's a whole bunch of ways that we can get you to interact here with the group. So let's see. Just trying to read comments here at the same time.
Tracy has a good comment in here. She was on a call today. Rob Kent mentioned that they were trying to get the minutes per session reduced so that you can still get reimbursed at the same rate. There is not any more info on this, but Rob Kent mentioned they were advocating for it.
Okay, good, excellent. So the other, you know, we don't have any other questions coming in right now. So just a reminder that if you've never done telemedicine, you know, before, as a lot of you guys probably haven't, because you know, there hasn't been a great way to get paid for it. You know, pay particular attention to how we're delivering this. We kind of talked about that briefly, but you know, make sure that the platform that you are using is compliant for the HIPAA standards. The 42 CFR standards, you know, those are pretty hard to hit. They're pretty specific. However, if you're not, you know, if you're not recording the session and basically once you hang up the call and everything's gone, that should meet most of those. So I wouldn't be super worried about on the 42 CFR Part 2 level. If it's HIPAA compliant, you should be good from the security point. Didn't the CARES, so another comment from Tracy, didn't the CARES Act align 42 CFR with HIPAA? It, from the security standpoint, it did. To the best of my knowledge, I haven't compared the two documents side by side, but to the best of my knowledge, it did from the security side. That's why I was saying, if you have, you know, if you're meeting the HIPAA requirements for security, you should be fine if you're a 42 CFR facility. So, quick point, if you have an option to integrate telehealth with your EMR, that would probably be the best method, as long as it's compliant. You know, if you don't have capabilities of implementing, you know, telehealth within your EHR, your EMR platform, you know, you can look at things like the doxy.me, that is HIPAA compliant, and it is free as well. So that's a big win. You know, price point is always a consideration right now with all these organizations.
One thing I wanted to bring up too, from the OMH side, if you're billing telephonic encounters, they being OMH want you to use the same CPT code as if that was being provided in person. And you do still have to append the GT or 95 modifier. I know that every agency seems to have a slightly different way of billing but the OMH guidance said that Medicaid fee-for-service and managed care providers need to use 95 or GT for the duration of the disaster emergency. This does include telephone only services.
Excellent. Okay. So once again, if you guys have questions or comments, please get the, please enter them in the chat box, or if you raise your hand, I can unmute your line as well. We don't have a specific agenda for today. It is literally reliant upon participation from you guys as the participants. So if you guys have questions, comments, concerns, even if you have a question that you need to ask the group, that is more than appropriate to ask in this setting. So, and another comment from Tracy, just a heads up, you might want to check with insurance company. Blue Cross Blue Shield told us to use the GQ for telephonic and GT, the 95 for telepractice. So every payer is going to be potentially slightly different. So if you're working with a particular payer, there are some guidance out there, like Katie had mentioned on both of our sites. We have some information from some private payers. It's not complete 100%, but you do want to make sure you're checked specifically for private payers. So I know same thing with like Fidelis and United. They're putting out their own guidance on, and as when I reached out to United, or not necessarily me, but when our team reached out to United, basically we said due to how rapidly everything is changing, they asked us to direct everybody directly to their website for specific guidance on that. So I think that's going to apply for a lot of the private payers as well. So from Jamie, can you speak to Article 28 billing for telephone and telehealth services for psychotherapy?
So that would have been a good question more for yesterday because it's Article 28, but we have the time, so let's talk about it. I don't know if you were on the call yesterday, Jamie, but we did kind of go over some of these billing lanes that DOH has put in place for, facilities that fall under their umbrella. So for psychotherapy, it's not explicitly stated, but you'll want to look at the billing lanes on page 4 of the DOH FAQ document, which is again on both of our websites. It sounds like that would fall into, I'm guessing, lane 2, which is assessment and patient management by all other practitioners, including a psychologist. And you can do that for new or established patients by phone. They want you using a GQ modifier for those codes, and they specifically state GQ, which is typically a store and forward modifier, because they want to track the utilization during the pandemic. I'm doing a quick word search throughout this document because it is quite large. They don't have anything specific to psychotherapy. And I'm doing a quick search in the OMH document too, just to double check. They don't really talk about specific services. It's more geared towards clinic setting and provider, which really directs the way that you would bill. So I would just advise you to really look at that 6-lane billing guide, and the FAQ document goes into a very comprehensive overview of each of those lanes, which should help you kind of find your answer, but I would refer you to lane 2.
Excellent. So, and all these documents that we're referencing, and correct me if I'm wrong, most of them are, if not all of them, are available on either one of our websites.
Yes, Krista is working on putting up, I think, another 7 or 8 documents I sent her this morning. Yeah. And I know that our communications person, Phil, just got everything up in the last few hours. So these websites are updated pretty much daily at this point. Our communications teams have been really good about keeping the information as up to date as possible, replacing old documents with ones that get updated. So when in doubt, refer to those websites or reach out to either of us directly. As you can see, our emails are on the screen.
Yep, excellent. So I do know that one of the local programs that we work with was specifically asking and looking for some help on how to do some patient assessment stuff remotely. So there are some resources out there. I can actually provide a link after this gets done for some equipment. It's not massively expensive, but it's not massively cheap either. If you're looking to do some basic patient assessments remotely, you can use Zoom to do that. Zoom for Healthcare, which is different than the open Zoom platform that we're using now. The Zoom for Healthcare does have a BA attached to that, so that would be compliant. And you can order a USB stethoscope, so the provider can do lung sounds. They do otoscopes and stuff like that. You're looking at $200 to $300 for each device. So basically, under $1,000, you could get a couple devices to assist doing a remote patient assessment. Just remember that a lot of times on patient assessments, a lot of times is done by nursing and clinical staff. So if, for example, and correct me if you got guidance otherwise, Katie, so I don't want to speak wrong and have it be gospel, but your nursing staff can go in and do your blood pressure and your respiratory rate and and your pulse oximetry and stuff like that, and your general clinical stuff that's usually done by the nurse during rooming anyways, and that information can be provided to the physician, and then use that USB stethoscope to listen to lung sounds if there's something that you need to listen to, etc. So another question from Bree.
Yeah, I see that. So I just responded to you, Bree, if you're an OMH or OASAS licensed facility, as that is the focus today, but I don't know if that would apply. This sounds like a question that would have come up yesterday, but the Place of Service Code of 02, we did find out some clarification on this yesterday. So in the Medicare world, the previously allowed telehealth services before the pandemic are still to be billed with the Place of Service Code of 02, but the newly allowable services that have been opened up as a part of the CARES Act, which include a lot of hospital-based services in intensive care, pediatric care, neonatal, things like that, those are to be billed with a modifier 95, and the Place of Service Code that you would normally use if the patient was in front of you, which can be like 11 or 12 most commonly. So keep that in mind in the Medicare space, that is how you would bill. I hope that answers your question, or if anybody else who's on the line is experiencing similar struggles as Bree, feel free to chime in.
Yeah, O2 is only people. Yeah, and I think if you have drop downs within your EMR, the traditional coding practices are sometimes built in, and these additional modifiers may or not be available as a drop down. So that's an interesting, just because these waivers and guidance is being kind of done on the fly. So if you have if some of these options are built in within your EMR, they may not necessarily be available. So I'm wondering if anybody else has run into that problem. That is kind of a good point. And Bree, if that didn't answer your question, we can certainly unmute you too, and we can get additional clarification. All right. So anything else? Any other questions? If anybody, if you want us to unmute you, if you have a question, concern, if you're looking for hey, what is anybody else doing for this example? We'll be glad to unmute your line. All right, yeah. So Bree, you responded that she's OMH. So, but if you're looking just for some guidance from other organizations on how they're particularly handling a situation or how they're doing something, let me know. Raise your hand or put it in the chat box, and we will unmute your line and let you ask your question or, or anything like that. So from Tammy Smith, what are OASIS?
So it's interesting that you're having a struggle with place of service in an OMH or OASAS world because, neither of those state agencies have said anything about place of service. They follow the 95 or GT modifier as I understand it, and I'm reading. So I don't know, OMH and OASAS refer to Medicaid and Medicaid managed care. So I don't know why the place of service code would be coming into play here. Yeah, I mean, I'm looking through the OMH and OASAS guidance documents. They don't talk about place of service. So if you're billing Medicare professional, I'm going to take my OASAS hat off and just talk about Medicare. If you're billing for Medicare patients, you would follow the guidance that I just explained. Where traditional telehealth Medicare services prior pandemic are place of service code 02. New services that have been added as of March 27th with the CARES Act are billed with modifier 95 and the place of service that you would normally bill if the patient was face-to-face with you.
All right. Okay. So yeah, so she got a thank you from Tammy. So it looks like that clarified that question. So once again, any other questions, or if anybody wants us to unmute your line, I know we've had some internal discussions at our own agencies. Tracy Hire, I don't know whether you're in a position that you want to. I know we were talking about stuff ahead of time. I don't know whether you have anything you want to add in right now or not. I'm going to unmute your line, and if you do, great, and if you don't, we will continue moving on here. So you're unmuted, Tracy.
I don't have anything other than the same thing I kind of said yesterday. After being on a behavioral health committee meeting, we learned that because of the CBOs have less manpower to keep up with all these updates, there were some facilities that were getting, like the hospital facilities were consolidating all the updates and then passing it down to the private practices and the CBOs. So we're going to look into that and see if we can provide that service for everyone also.
Excellent. That's a really, really good point. So we did talk about this yesterday on the last webinar. So if you're a larger organization, or even if you're not, if you're consolidating stuff down that could potentially be available to other entities, please feel free to share that both with Katie and myself. We'll take a look at it, and we can certainly get it added to both of our sites to provide, to help other organizations as well. So, if you put in the time, put in the effort to get, to kind of condense those down, we'd be glad to post those up for other people to utilize as well. So that is a really good point. Sharing is definitely a good thing right now with some of the smaller agencies having limited resources. So excellent. Once again, we're caught up in questions. So if you have a question, go ahead and get that entered now. Or if you want to be unmuted, if you want to ask a general question regarding, how other organizations are handling anything specific, we can certainly unmute your line and allow you to get input from the group as well. So go ahead and get your questions entered in now, and we will kind of continue on. We're running towards the end of the hour, but we're not quite there yet. So we can always end early if we need to. But so one from Megan. So to bill psychotherapy notes or psychotherapy codes in Article 28 clinic, would a video component be required? If it is a telephonic service only, would it be billed as the 994441 and 99443?
So to answer your question, Megan, if it's telephone only in an Article 28 setting, and I'm referring to the DOH FAQ document, so what they're saying is in lane 1, evaluation and management services, which would be your physicians, mid-levels, midwives, dentists, and nurses, you would bill 99211 if it's a nurse with a GQ modifier, or the codes you described, the 99441 to 99443, and those are your telephone codes. If it's any other practitioner billing the fee schedule, so a psychologist is an example that's cited, any existing procedure codes for services appropriate to be delivered by telephone can be billed with a GQ modifier for tracking purposes.
Excellent.
So again, I refer you guys back to the documents that exist. DOH, OMH, and OASAS have come out with their own FAQ documents. The DOH one is 26 pages long, so it really does cover, I think, a lot of the questions they're being asked, and leaves very little to be misinterpreted at this point. There are still some nuances that come up, but there is they have an email address, and I'm gonna find it and put it into the chat box, that if you can't find anything at all in the guidance documents or the FAQ documents, that you refer to this email address. And I'm just looking for it because this document is massive, so I'll type it in when I find it. Here it is.
Thanks. So once again, here we're caught up on questions here. So if you do have a question, go ahead and get that entered. And we're still about 15 minutes out from our scheduled time, but if we're not getting any additional questions, or comments or anybody that's looking for some input from how other entities are accomplishing specific things, we can go ahead and begin to wrap up the conference here. So if you do have any more questions, go ahead and get them entered now, and we will get them answered before we wrap up. All right. Well, it doesn't look like we're having any more questions come in. If it's a question that you don't feel comfortable asking to the group, our emails are both posted up on your screen. Feel free to email both either Katie or myself. The one thing I want to add is if you have a technology struggle right now, please reach out to me. I am more technology driven, and Katie is much more in tune with some of the billing guidances and stuff like that. So if you have something that you need technology wise, if you're struggling, please reach out. I may not be able to necessarily come on site, but I can certainly give you some guidance and remote support if I'm able to do that. So we're certainly here to help. So we do have another question from Bree. Can you confirm any other E&M codes for the 99201 and the 99215 needed if a HE modifier following the 95 modifier?
Bree, I have not seen anything in any of the guidance around an HE modifier. I know that's for a mental health program, but OMH and DOH and OASAS in the history of telehealth have never mentioned that modifier. It's just been the 95 or GT.
Excellent. All
You
right.
are welcome.
Yeah, absolutely. So, the biggest thing is I just want to reiterate that, Katie and I are here to kind of provide guidance to everybody that we can. So feel free to email both of us. I know we really appreciate everything that you guys are doing, to try to figure out how to continue to care for your patients, and we're kind of in the background trying to provide support, for what we can do. So we greatly appreciate everything that you guys are doing, caring for your patients, and and jumping through all these hoops. And I know it's tough on everybody. So we really, really, really appreciate everything that you guys are doing, and helping your patients. So, so with no other questions coming in, I guess we're going to go ahead and wrap up the session for today. So once again, if you have questions, shoot either Katie or myself an email. We'll be glad to follow up, offline as well. The recordings, as well as the questions that we asked and answered, will be available here after the meeting. So we'll get it posted. Both the video will get posted, and the Q&A reference document will be available as well. So so you can go back and look at some of the answers that got asked, and what our interpretation of it was. So last call, if there's no other questions, we're going to go ahead and wrap up the session today. I'd like to thank everybody for participating. We greatly appreciate it. Anything from you, Katie?
No, I echo your same sentiments. Thank you for pulling together these sessions, and of course, reach out to us if you need anything at all telehealth related. We are here for you.
Excellent. Well, thank you, everybody. I hope you have a great day today, and please be safe out there, and let us know if you need something. Take care, everybody.
Bye-bye.